Full screen, please. Okay, now we can see your slides.
But this is wait a minute. Can you see the slide?
Yes, we can see, Dr. Koda Sensei. Please start. We can see very well. Can you hear me?
Yes, yes, I can hear you.
Okay.
But this is normal mode, not normal mode now. I'm sorry, so this image is not normal mode, but I can present by this slide.
Okay, good, please, no problem.
Okay. Thank you for your kind introduction and invitation on the honorable conference. I will talk about EUS-FNB for comprehensive genomic profiling in pancreatic biliary tumor in Japan, especially in our center. There are no COI with regard to this presentation. Okay. Sorry. Okay, let's start. Health insurance system had covered tissue-based comprehensive genomic profiling since June 2019 and liquid-based CZP since August 2091 in Japan. And this slide shows that the number of patients received CZP are increasing every year. NCCN guidelines recommend MSI, MMR, TMB, and additional molecular testing before systemic therapy for advanced and metastatic pancreatic biliary cancer. And precision medicine will play more important roles. And this graph shows the estimated age standardized incidence rate of pancreatic cancer in each country. In Japan, 11.7 males and 7.7 females are suffering from pancreatic cancer every year, and the rate of incidence was high group among the world nations. On the other hand, new pancreatic patients in Egypt were same as the world average level. The morbidity and the mortality were increasing every year, and pancreatic cancer is the first cause of death of malignant cancer in Japan. Okay, this map shows the estimated age standardized incidence rate of pancreatic cancer. Japan and European countries have highest morbidity in the world, but it seems that there are no geological characteristics in pancreatic cancer. Next slide. This slide shows the world map of biliary tract cancer. You know, biliary tract cancer has geological characteristics, and this fact is different from pancreatic cancer. cholangiocarcinoma are frequently seen in East Asia, including Japan and Southeast Asian countries. However, gallbladder cancers are frequently seen in Japan, South Asia, and Chile. Both BTC distribution are different from each other. However, Japan has the highest morbidity in both BTCs, and 3 to 3.5 over 100,000 cholangiocarcinoma and 7 over 100,000 gallbladder cancer patients occur per year in Japan. This figure shows the mutation spectra of BTC published from National Cancer Center, Japan. BTC has not only geological features, but also anatomical and genomic features. Cancers from each part of biliary tract have their own specific driver alterations. About 40% BTC patients have any targeted therapeutic alterations. So precision medicine is more meaningful for BTC treatment. To obtain the tumor tissue, we have to select the appropriate tissue sampling method among surgical resection, percutaneous liver biopsy, ERCP, and USTA. Today I will talk about two items. First is how to obtain samples for CGP by using USTA in pancreatic and biliary tumor patients. Second is CGP analysis result in clinical setting from our center. Let me talk about first one. This slide shows the 7 genomic panel tests in Aichi Cancer Center. 5 genomic panel tests including Foundation 1 CDX, NCC OncoPanel, GenMine-Top, Foundation 1 Liquid CDX, and Guardant 360 are mainly used as insurance-covered test. I will talk about tissue-based CGP today. Cody. Okay, this slide we describe that the flow chart of obtaining CGP samples in Aichi Cancer Center. We usually use surgical specimens for the first time, and if surgical specimens are determined inadequate by pathologist or there are no surgical specimens, secondly we perform USTA. If USTA are difficult to perform or that USTA samples are not adequate for CGP, we try to perform percutaneous liver biopsy. Finally, if any of the tissue samples are inadequate, we choose liquid biopsies. We have standard rules into USTA for CGP sample in our center. For the unresectable pancreatobiliary tumors, we try to use 19-gauge FNB needle without suction, not to involve much blood, and check the tumor cell mount and cellularity by using rapid on-site cytology evaluation, so-called ROSE. Finally, we try to perform FNB for 3 times at least to obtain sufficient amount of tissue. First of all, I'll talk about endoscopic selections. We usually use a type of endoscope, 2 oblique viewing and 1 forward viewing scope, and commonly use GF-UCT 260 basically. But we had better change the type of scope according to the situation. These figures show the characteristics of TGF-UCT 260J and EG740UT. Here, CAP device can fix the target region like this and make puncture easier by using TGF-UCT 260J. On the other hand, EG740UT allows for a very wide range of angle adjustment. So taking advantage of these beneficial point, TGF-UCT 260J is used for subepithelial lesions, pelvic lesions, and altered anatomy cases. And EGV-740UT is useful for the lesion difficulty in puncturing due to angle limitations. Next, about needle selection. Fine needle is easy to puncture due to the sharpness of the tip. In contrast, Koda needle is difficult to puncture because of the needle resistance. As the needle gauge becomes larger from 25 gauge to 19 gauge, puncture tends to be more difficult, but sample size becomes larger. Based on these features, we have to select the appropriate needles. These three meta-analysis and RCT comparing the needle size showed diagnostic ability among which needle size seemed to be similar. Which needle design is better, fine needle or cold needle? Two meta-analyses show that there are two significant differences of diagnostic accuracy between fine needle and Koda needles. However, both studies showed the Koda needle requires fewer passes to establish the diagnosis. There are no differences of diagnostic ability in each needle size and needle design, so we should select a needle based on the purpose of sampling, target location, target size, physician skill, and so on. What if the purpose of tissue sampling is CZP? One study showed the rate of tissue adequacy for CZP is higher with Koda needle than fine needle. So to obtain a larger amount of tissue for CZP, a larger size Koda needle is required. A third is about the suction stylet. And there are three RCT comparing diagnostic ability between with and without suction. All of these RCT showed that 10 to 20 milliliter syringe suction increase sensitivity and diagnostic accuracy as compared with no suction. Other suction techniques, such as high negative pressure with 50 milliliter syringe suction, wet suction, and slow pull technique have been reported. Sampling adequacy and cellularity of these suction techniques were superior to standard suction, but none of them improved diagnostic accuracy. Since there is limited evidence that these suction techniques have more advantages, ESG recommends using the standard suction technique with 10 to 20 milliliter syringe negative pressure. About the use of stylet, there are three RCT comparing diagnostic ability between with and without the needle stylet. All of these RCT showed no advantages of using needle spallet in diagnostic accuracy and prevention of contamination by gastrointestinal wall cells. So ESG does not recommend using needle stylet when puncturing target regions. From now, I will now present the CGP result for pancreatobiliary tumor cases at this center. This table shows the patient characteristics of pancreatic tumor and biliary tumor from October 2019 to March 2024. Let's focus on pancreatic tumor first. Adequacy of each sampling method for pancreatic tumor are listed in this table. Surgical specimen were 89%, percutaneous liver biopsy 69.2%, and USTA was 67.7% adequate in this study. Among USTA, 19 gauge and FNB needle had significant high adequacy for CGP, and there is no significant difference between surgical specimen and EUS-FNB. So as to pancreatic tumors, 90 gauge FNB needle has significant factors associated with samples adequacy. Next, let me focus on biliary tumors. Adequacy of each sampling method for biliary tumor listed in this table. Surgical specimen were 95.7% percutaneous, liver biopsy 75%, and the USDA was 83% adequate samples for CGP. And over 22 gauge needle has high adequacy of 19%. Among USDA, over 22 gauge FNB needle had significantly associated with samples adequacy. Of the 273 US FNB cases, adverse events were observed in 1.1%, with 2 of the 3 cases requiring blood transfusion and 1 requiring endoscopic hemostasis. We summarize that using 19 gauge FNB needle was useful for obtaining CGP samples for a pancreatic tumor, and using over 22 gauge FNB needle was significant factor associated with CGP samples adequacy for biliary tumor patients. Next, second is CGP analysis result in clinical setting in our hospital. This slide shows that CGP result in pancreatic tumor patients and picked up cases with actionable alterations. 11 kinds of actionable alterations were detected in this study, and the most frequent alterations were BRCA1 or 2 mutations. And total 13.9 pancreatic tumor patients had any actionable alterations, but only 4.2% patients could enroll the treatment. Right chart indicate actionable alterations related with PDAC, pancreatic ductal adenocarcinoma, and you can understand how rarely actionable alterations were detected in PDAC. Next is the result of biliary tumors CGP analysis result. IDH1 and FGFR2 fusions were detected in only ICC. intrahepatic cholangiocarcinoma, and ABB2 amplification were commonly detected in gallbladder tumors. There were 7 cases with tumor mutation burden high in gallbladder tumors. Total 36.2% biliary tumor patients had any actionable alterations, and 12.4% patients could enroll the treatment. Sorry, I skipped. This is summary 2. Actionable alterations were detected in 13.9% pancreatic tumor patients and 36.3% biliary tumor patients from our data. 4.2% of pancreatic tumor patients and 12.4% of biliary tumor patients were received treatment based on CZP. ICC and GB cancer, gallbladder cancer patients are recommended to be performed CZP. In conclusion, about EUS-FNB, the use of 19-gauge FNB needle for pancreatic tumor and over 22-gauge FNB needle for biliary tumor was deemed beneficial for CZP. Thank you.
Thank you, Koda Sensei, for your informative lecture. So, any question from the floor or panelists? So, Koda Sensei, during puncture by 19 gauge needle, some blood comes, so maybe contaminated by blood, much blood. Is this a big problem during CGB?
Blood confusion is not so big problem for CZP analysis because red blood cells have no nucleus.
Yes.
So no need, we don't have to consider about that. But blood confusion, if the blood confused to the sampling tissue, we can't detect the tumor tissue, white tissue. So we want to prevent the confusion of the blood.
How safe puncture by 19 gauge needle compared to 22 gauge needle? How safe? Is this similar regarding safety?
About safety, not so different between 19 gauge needle and 22 gauge needle. In our data, in our hospital data.
But maybe you prefer slow ball technique during 19 gauge needle, right?
When I performed the EUS-FNB by a 19 gauge needle, and much blood come back.
Yes.
In that situation, we use slow pull technique. But first choice is just puncture without suction and without silent.
I see.
But
thank you so much,
Dr. Mad, the puncture with the 19 gauge needle is more difficult. It is more difficult than the 22. What about your idea about the puncture? Is it for training or for the puncture with 22 is more easy for the trainees? So yes. You ask about now you asked for pancreatic tumor, you have to go with 19 gauge needle. In our country, we use mostly 22 gauge needle.
Yeah. Of course, the safety is the most important thing for the patient. So if the risk of complication is higher, we use 22 case by case. But first choice is 19 gauge. But sometimes puncture is difficult from D1 or D2 or another portion. In that case, we use 22 gauge.
Yes.
So
what
we
about
choose
25?
case by case.
25 you didn't use or no? You use 25. I didn't do it before.
Sometimes use, but very rare.
Yes.
Almost all the cases we can perform 19 gauge or 22 gauge needle.
Yes. Thank you.
Thank you for a lecture, but I'm asking about, you start a target gene therapy for pancreatic cancer and extract the gene variant for pancreas and start a target gene therapy?
Sorry. Sorry, I couldn't hear you. Can you say that again?
Okay. For pancreatic cancer in Japan, you extract gene variants and start a targeted gene therapy for pancreatic cancer?
Yes. In our center, we first perform chemotherapy as a first regimen. And before a second regimen, we usually order the genome profiling test, CGP. And prepare the chance we perform EUS-FNB first when I diagnose the lesion first. Sorry, I can't say correctly.
Okay. So, Dr. Koda, Dr. Professor Syed Ghunaim, now he is at Kyoto University. He joined us with the Zoom. He asked about the new acquire S needle. Have you any experience about this new needle?
Yes. I use some cases. But Acquire S, we use the 22 gauge Acquire S. But we usually use 22 gauge needle Trident now. So Trident is easier for me to puncture the target lesions. But the amount of the tissue, we can get much tissue by using Acquire S. So case by case, we change the needle. If we want to get much tissue, one selection is Acquire S. But easy puncture, I use Trident, 22 gauge.
I see. Thank you again, Dr. Koda, for your informative lecture. Now we move to the third speaker.
Thank you, Professor Koda, for this informative presentation. I feel proud and honored to introduce the next speaker, Professor Shen Habba. Shen Habba will introduce early pancreatic cancer. Welcome, Dr. Shen Habba.